for joining us today. And I am excited to share a little bit about the Children's Advocacy Center of Pierce County and what that is and what we do. So just a little bit of an overview of what we'll cover today. History of what the CAC movement is, what our CAC in Pierce County looks like, what our Pierce County protocol for child abuse is, the services that we provide, a little bit about forensic interviews, medical evaluations, and some prevention tips for you. As Ashley stated, there's a chat button that we will be monitoring through, so feel free to ask any questions and happy to answer them. So a little bit about the CAC movement. This gentleman here that you see on your screen is essentially considered the founding father of the CAC movement. Bud Kramer was a former district attorney and congressman in Huntsville, Alabama. And through his work prosecuting child abuse cases, he found that systems were not working well together. He found that many people were involved, kids were being interviewed multiple times, work was being duplicated, and then as a result, children and families were dropping out of the process. So he had a vision for a more coordinated team to address the needs of child abuse victims, and his goal was to get agencies and disciplines that were not used to working together. So law enforcement, medical professionals, prosecutors, child protective services. Huntsville, Alabama is the home to the national CAC now, and they provide support to CACs all over the country. This is a little diagram that kind of shows what kids experience with and without CACs. So the one on the left, at least my left in the red, shows what a child experiences without a CAC. So say a child makes a disclosure of sexual abuse or physical abuse at school. Maybe the school counselor interviews the child. Maybe the school then calls patrol, who responds to the school and interviews the child again. Maybe patrol notifies a detective, who then interviews the child for a third time. Somewhere in there, CPS is contacted and might do their own interview. Or maybe the child has medical needs and they go to a hospital or a doctor's office, and they're asked again about their disclosure and what happened. So the diagram in blue shows kind of how CACs are child-centered. So everyone comes to the child. Multidisciplinary team members, different disciplines work together to make the best experience for the child and to make it so they do not have to repeat what happened to them over and over and over again. So what is a CAC, or a Children's Advocacy Center? It's a child center and safe environment. Historically, interviews of these topics might be done in police stations or the principal's office, places that kids might associate with being in trouble. They were initially designed to address the investigation and prosecution of child sexual abuse, but they have expanded to also include physical abuse, commercially sexually exploited youth, and prevention and outreach services. So the goal of the CAC is, as you see on the screen, it's a neutral setting, child-centered, and a place where a team of experts collaborate to investigate and ultimately prosecute child abuse. So why do we need a coordinated response? This is kind of the whole reason behind CACs. Having a coordinated response to child abuse leads to better outcomes. These statistics, I realize they're a couple years old, but the most recent ones that there are, it just shows kind of the bandwidth of the problem. In Washington state, there's nearly 10,000 kids in foster care. As you can see, there's 7 million reports of maltreatment made in a year. That doesn't mean all of them are substantiated or that all of those kids experienced abuse or neglect, but that's the sheer volume of reports that are made that are investigated. So a little bit about Pierce County protocol. The CAC operates amongst the multidisciplinary team by the protocol. So Washington state law requires that each county develop a written protocol of how that county is going to handle child abuse cases. So why have a protocol? It keeps the focus on the child, it clarifies roles and expectations, and it coordinates services, ultimately reducing duplication. And so as you can see, the protocol specifically says who should be involved in the coordination and investigation, prosecution of child abuse, and what types of abuse should be listed in the protocol. It's renewed every 2 years on even years. So 2022 was the last revision that there was, and disciplines from all across the county sign on to this protocol: schools, law enforcement, fire, EMS, medical personnel, prosecutor's office. So a little bit about child sexual abuse. As I mentioned earlier, CACs were initially developed to address child sexual abuse. However, they've evolved to also investigate physical abuse, kids who witness violence, as I mentioned. But these statistics speak to why a coordinated response is needed. And I think the most important thing to glean from these statistics is that stranger danger is a myth when it comes to child sexual abuse. Abusers can be found in any place that children gather: schools, churches, recreation centers, sports leagues. They look and act like everyone else, and only about 10% of children are abused by a stranger. 90% of victims know their abuser. And so it's really important to understand a little bit about who the offenders are, but also that the actual number of children who experience sexual abuse is not actually known. And there's lots of reasons for that. Many kids never tell. Many kids might not disclose until adulthood. Many kids might tell someone who is not a demanded reporter. They might tell a family member or a friend, and it doesn't get reported. And so it's important to recognize that the sheer number of children who experience sexual abuse is not known. And also important to recognize that false reports are rare. Only about 4 to 8% of reports are actually determined to be false allegations. So criteria for cases to come through the CAC. This kind of outlines the types of child abuse cases that we see here. So all sexual abuse cases, child fatalities, online child sexual exploitation, severe to moderate physical abuse, which can be any of the ones that are listed, and also children that witness felony level violence. So this is our location. We are part of Mary Bridge Children's Hospital. So we're a hospital-based CAC right across from Mary Bridge. CACs are different all over the country. Some are prosecution-based, some are law enforcement-based, some are nonprofit, some don't have an actual physical location that co-locates different disciplines. Our CAC, we are the only hospital-based CAC in Washington. And Mary Bridge is also a pediatric trauma center. So we get kids from outside of Pierce County sometimes if there's concerns for abuse. Like Ashley mentioned earlier, we're accredited through the National Children's Alliance, and that just outlines standards of care that we abide by and meet while providing services to kids that we see. A little bit about our staff. So we have a child abuse pediatrician, 2 nurse practitioners. There are several forensic interviewers, child forensic interviewers, which you'll learn more about. 2 are employed by the Pierce County Prosecutor's Office, and then 2 are employed by Mary Bridge. They're social workers, victim advocates, and we have linkage agreements to provide trauma-informed, evidence-based mental health care to kids that come through our center, so we can refer out to those community agencies. So what happens at the CAC? We'll dive into each of these a little bit more moving forward, but just to get a gist of it, if a child comes to the CAC for an interview appointment, before that appointment will happen, the detective, and if they're CPS, they will be present at the CAC as well. They will meet with the non-offending caregiver prior to the interview happening. Then then forensic interviews happen. And then there's another meeting after the conclusion of the interview. Medical evaluations and social work interventions take place during and after the interviews. as well as ongoing victim advocacy, follow-up phone calls, and ongoing support. One of the things that we have for our multidisciplinary team is case review. And the purpose of case review is to get all the different disciplines together to talk about the cases that they're investigating, to see, are there outstanding tasks? Does someone know information that another discipline doesn't? There's RCWs that permit information sharing amongst multidisciplinary teams. And so the goal is to ensure that the children and their non-offending caregivers have the services and support that they need throughout this process. And lastly, we recently started providing a support group to non-offending parents and caregivers of children who've experienced sexual abuse. Our first support group, and it was pretty successful, and we will continue to do that here at the CAC. So what is a forensic interview? I feel like that's a question that we get a lot. So it's important to understand what a forensic interview is. It's a formal interview aimed at gathering reliable information. It's unbiased and objective, and it's conducted by a trained forensic interviewer. All interviews are video and audio recorded, and investigators, CPS or law enforcement observe from another room. It's also important to note that the recording does not replace the need for the child to testify if the case goes to trial. However, there are certain laws that are taken into consideration regarding whether the interview should be shown in court or not, or whether the child does have to testify based on their age. That's the question we get a lot, is if an individual's child receives an interview, sometimes it's assumed that that means they won't have to talk about what happened to them again. And the goal of the forensic interview, like I said, is to gather as much information and as reliable as information as possible during the investigation, so those decisions can be made regarding prosecution. Also, it's also important to note that there's RCWs that protect forensic interviews, so people can't just get copies of them. It requires a court order to release a forensic interview for people other than, if the case is being prosecuted, to be shown, and that doesn't happen very often. This is just a good diagram to kind of explain how forensic interviews work. I'm not a trained forensic interviewer, so I won't say that I am, but this just shows kind of how when you use open-ended prompts with the child, or when you're asking questions, you're going to get more information. And since the goal of a forensic interview is to gather as much and as reliable as information as you can, open-ended prompts and questions are what are used rather than closed-ended questions, such as questions that would get you yes or no answers. And they're focused questions regarding the incident the child has disclosed. So what qualifies for a forensic interview? So this is per our Pierce County protocol. So any child that has disclosed sexual abuse or felony level physical abuse qualifies for a forensic interview. Interviews are requested by law enforcement as part of the legal investigation. Per our protocol, we primarily interview children ages 3 to 15. However, we can interview 16 and 17-year-olds in special circumstances, including maybe the child has considerable mental health needs, maybe they are developmentally fall within the 3 to 15 age range. We do interview vulnerable adults that fall into that age range developmentally. Maybe the child would benefit from in-person contact with an advocate, or maybe they would benefit from a medical evaluation at the same time as their interview appointment. And you'll see here on the screen just other examples of what qualifies for a forensic interview. Like I mentioned, children that have witnessed a violent crime, when there's been a confession by a suspect, or if the abuse was witnessed or recorded. So sometimes maybe a child hasn't disclosed, but someone else has disclosed that they've witnessed the abuse. So when we talk about interviews, it's important to talk about influences on disclosure. So when you see needing to tell versus opportunity to tell, needing to tell talks really about maybe the child realizes what's happening is not normal, and they're having trouble coping with the abuse and experiencing emotional distress, and they're wanting something done about it. Opportunity to tell can reference just being asked about it, being asked by someone they trust about it, and expecting to be believed. So as far as barriers to disclosure, there's lots of reasons that kids don't disclose. Family disruption, divorce, separation, concerns that will happen, concerns that they'll go into foster care. As I mentioned earlier, 90% of individuals, 90% of children who experience sexual abuse are abused by someone they know and trust. And so the child might have concern that the perpetrator is going to get in trouble. They might have concerns about the perpetrator having to move out of their home and how that would impact the family financially. They might worry they're not going to be believed. And we know that all of these are true. Kids do experience these. While many caregivers and parents believe their children when there's a disclosure of sexual abuse, there are some kids that aren't believed. And just some factors for, risk factors for recantation. These kind of speak for themselves, but obviously if the child is not believed about the abuse, if they are still residing in the same home as the perpetrator, those are all risk factors as far as possibly recanting after their initial disclosure. All right, so medical evaluations at the CAC. I don't know if any of our medical providers are on here, so hopefully I'll talk about these correctly. But I think it's important to talk about medical evaluations and what they entail, because I think it's a common misconception as far as what actually happens when a kid comes to the CAC for a medical evaluation. So the Child Abuse Intervention Department, part of Mary Bridge Children's Hospital, provides medical evaluations to children that experience physical and sexual abuse. They can be acute or non-acute, depending on the triage and the need of the child. Anyone can refer a child to CADE for a potential medical evaluation, and then those, the concerns are triaged with our medical team to determine is it in the child's best interest to receive a medical, and does it make sense to bring them in here? So you'll see here a little bit about the criteria for a medical evaluation. It's important to note that medical evaluations are non-invasive and they're completely voluntary. So they are child-led, and if a child is not comfortable, they're not going to be forced to do a medical evaluation. There's a piece of equipment called a colposcope that is used during the exam, which acts as a magnifying glass in a way that allows the provider to look at genital areas for any potential injuries if needed. Like I said, it's non-invasive. There's nothing inserted, and I think that's a big common misconception as far as the medical evaluations that are provided. And I think I mentioned that kids have complete control over the situation, and many children benefit from being able to talk to a medical provider about their body and what happened. So a few things to remember. Exams are not done to determine if something happened or provide proof of abuse. There's a lot of phone calls that we get sometimes where parents might be concerned that something happened and their child needs a medical evaluation to see if they were abused. That's not the purpose of these medical evaluations. There's findings in less than 5% of cases, and it's very common for medical providers to testify to why normal is normal. And I think there's reasons why there's findings in a very small amount of cases. Again, going back to kids are abused by people that they know. And offenders strive to maintain secrecy, and they strive to continue the abuse. And so most of the time, and most often, offenders are not going to do something that hurts the child or causes them pain. And again, we talked about delayed disclosures. Many kids might disclose years, days, weeks, months, years after the fact. And when that happens, obviously, we can still provide medical evaluations if there's concerns that child has about their body, or to provide reassurance. But as far as forensic findings, they're unlikely in those situations. So a little bit about minimal facts interviewing. This is something that there's training provided to first responders. So CPS investigators receive this training, and minimal facts was created by Department of Children, Youth, and Families safety team, as well as some forensic interviewers in the local area. So I think one of the most important things to remember is, if a child makes a disclosure to you, it needs to be reported to law enforcement and Child Protective Services. When disclosures happen, many people want to get more information about the crime itself, but the crime itself does not matter in regards to the child's safety at that moment. And questions about the crime itself, specific questions, are what can lead to problems in the investigation. So you don't need to figure out everything before investigators or first responders respond. And to assess safety, so say a child makes a disclosure to you, and you're trying to determine, is this child safe to go home, or what are the next steps? After you've made the calls, questions you can ask are about offender access. Who lives in your home? Where's that person today? When will you see them again? And that will help dictate who your first call should be to. Obviously, if a child's disclosing sexual abuse and assault, law enforcement needs to be called. Child Protective Services as well, but there's different timeframes that agencies have to respond to concerns, and law enforcement is the immediate response that you need in those situations. So just some tips on talking with kids who might have made a disclosure to you is, let go of the habit of asking who, what, when, where, why, kind of going back to not asking direct questions about the crime that they're disclosing, asking one question at a time. I think, kind of like I mentioned, adults want to try and get as much information as they can in these situations. However, think about whether you need that information, or whether you have the information to determine if that child's safe at that time. Maybe that information is not needed, and you can just provide reassurance to the child about they'll be able to talk to someone else about what they just told you, and that will make sure that they're safe today. Going back about, when I talked about forensic interviews, asking closed-end questions is going to lead to yes/no questions. And so getting information using open-ended prompts about safety, tell me everything that happened, and avoiding direct questions is best. So I think just a little review on mandatory reporting. This is RCW for mandatory reporting in Washington. I have one for sexual abuse, and I think physical abuse is the next slide. But just recognizing that the RCW says that a report should be made to the appropriate law enforcement agency and to the department. So the department in this situation means Child Protective Services. And this is important to remember. There are, as part of the multidisciplinary team I mentioned earlier, there's constant information sharing that is going on. However, the time frame for that information sharing can vary by agency. Like I said, everyone has different timeframes that they work within, and different requirements of their agency. So in order to not delay any reporting and notification, both law enforcement and Child Protective Services should be contacted. Physical abuse is similar. There are things, the RCW is listed here if you want to go look it up, because there are things specific to vulnerable adults that it lists in the RCW as far as when to report physical abuse or assault of a vulnerable adult. And if you have questions about the RCW, I again encourage you to read it, because they can be confusing, but making sure you're reporting to both agencies is very important. And this just goes back to the information sharing that happens amongst the multidisciplinary team, specifically at case review and before, during investigations. So again, RCW allows sharing of information between CPS and law enforcement and the CAC. There's certain parameters where referrals are sent to law enforcement. But if you have a concern about a child's safety, never assume that another agency will get that information to them faster than you, which is why we encourage you to call both agencies. A common thing that we do see for kids coming to the CAC for interviews or even medical evaluations is maybe only CPS was contacted and law enforcement hasn't been contacted yet. And so sometimes that can delay the child receiving services, especially because forensic interview requests have to come from law enforcement. So specifically with sexual assault and physical abuse as well, it's important as far as the language that we use when talking about children who experience sexual abuse. So sexual assault and abuse is one of the few crimes that requires intense scrutiny into the believability of the victim and their description of events, and possibly the only crime where the suspect can successfully defend themselves by claiming the victim consented. So accountable language matters, and the way that we use to talk about sexual violence influences how, our response to the issue and how we perceive it. Language to avoid. So victim blaming, that can include information or comments about the victim's actions, demeanor, appearance. This type of language implies consent. And there's some specific quotes here that are often used. So outside the context of force, which can be physical, emotional, intimidation, coercion, all of these statements listed here imply consent, which is just not possible when it's a child victim. And so when working with victims of sexual assault or physical abuse, any type of abuse, really, it's important to understand that when someone's under attack, there's hardwired reflexes in their brain that take over. And freezing is typically the first brain reflex to a sexual assault. Kids are taught at a young age to listen to adults and be respectful to adults at home, school, and in the community. And it's common for kids in forensic interviews to say things like, I didn't know it was wrong because it was an adult, or why did I just freeze? Why didn't I move? So I know fight and flight is talked about a lot, and freeze has been, the freezing mechanism has been started to talk about more, but it is important to understand this in relation specifically to sexual assault and abuse, because this leads to a lot of shame and blame for victims when they don't understand how their body works. And it is, like I said, it is something that that they bring up. And so our social workers have started to talk to victims about those feelings and explain to them in a child-friendly and friendly way, in a way that they understand why that happened and how their brain caused that to happen. And then as far as just sexual assault prevention, I mentioned before, teaching kids to run, scream, or say no is not prevention. And why I say that is what I mentioned earlier, is we teach kids at a young age that they can't say no to authority figures. And they're not supposed to say no to mom or dad, or they're not supposed to say no to their teacher. And so just being aware of that and asking if a child does disclose to you, not asking, why didn't you tell? Instead, maybe ask them, what made it hard for you to tell? Don't ask, why didn't you leave? Help me understand what you were feeling at that time, at that moment. That takes the pressure off the victim, off the child, in making them feel like they should have done more or they should have done something when it wasn't their fault. So some basic prevention that we teach, things that you can do. Again, permitting white lies within context, right? Because obviously, in schools or in community programs, there's going to be rules about following directions and all of that. But permitting white lies, telling kids that it's okay to, if they feel uncomfortable and they don't feel right in a situation, that they can say a white lie to get out of that situation. We have tons of kids come in here who were able to end situations because they said they had to go to the bathroom, or they didn't feel good, they needed to call their mom. Teach kids to pay attention to the feelings in their body, butterflies in their tummy. That might signal to them that something's not okay. Teaching rules and boundaries can be similar to rules and boundaries that they have at school. Teaching kids that we don't use secrets. There can be surprises. Surprises can be things like a birthday surprise, but secrets are obviously things that it's a manipulation tactic that offenders often use. And so teaching kids that we don't tell secrets, we can keep surprises when we'll eventually share the information, but no secrets. And when in doubt, ask an adult or ask a safe person, and make discussions about sexual assault prevention routine and normal. They should be as routine and normal as any other childhood safety conversation that parents are having with kids. Wearing bike helmets, wearing your seatbelt. It shouldn't be a taboo subject. And the more that you talk about it with kids, the more comfortable they may become with it, and more likely they may disclose if something is happening to them. And I think I went pretty quickly through that, Ashley. So I don't know if there's any questions, or if I can talk more in depth about some things that would be helpful.
That is such great information. And just a reminder for all of our participants today, you can utilize that chat, or there's a Q&A box at the bottom of your screen. So Lindsay, I actually did have a question or just a thought, and maybe you could comment on this or just give some guidance. But I know I get outreach from a lot of community partners, such as teachers that become aware that there was a disclosure, or maybe a kid was removed, and they automatically want to send referrals, get them connected to behavioral health services. And so I'm wondering if you just have any guidance, or if you can just kind of explain, what kind of supports or resources are provided to kids who engage with the CAC for, to help address the trauma and any other mental health or resource needs that are identified.
Yeah, of course. I totally missed that part. But yeah, so when kids come to the CAC, every caregiver that brings them meets with a social worker to assess for resources, counseling, social determinants of health resources, food, housing, anything. For kids that are 13 and older or younger, if indicated, social workers meet with them. They conduct a mental health screening, safety planning if necessary. And one of our main goals is to connect children to therapy. So trauma-informed therapists that can help them begin their healing journey. So we do have linkage agreements with various community mental health agencies that we refer to kids to, or depending on insurance, we can work with the parents' insurance or crime victims' compensation as far as covering therapy. But every child that comes to the CAC that is willing, especially 13 and older, willing to engage in counseling, a referral is made, and resources are provided as far as services they can access following their appointment and throughout this journey. Our social workers also do follow-up support, and so they're reaching out to caregivers or other people caring for the child routinely after the appointment to see, are there barriers into getting them into treatment or therapy? Are there other resources that they're needing? Kind of how things have gone since the appointment. The appointment can be really overwhelming for people. Forensic interviews can be anywhere from 1 to 2 hours, depending on, even longer, depending on how much the child has to share. And then if they're having a medical evaluation, sometimes kids are here for a couple hours. And so it's good to check in with them and their caregiver 2 weeks after the appointment to see, like, now that things have settled down a little bit, like, what do you need and how can we help you get that? Did that answer your question?
Yeah,
Hopefully.
thank
Okay.
you.
Yeah.
There was just a clarifying question in the chat. Is the multi-care CAC the only one that's in Washington?
No, so there's CACs all throughout Washington. I think there's 5 counties that don't have a CAC. And like I mentioned earlier, so Washington's the only hospital-based CAC, not the only CAC in Washington. So different communities have CACs that are nonprofits, or they're prosecution-based, law enforcement-based, or they don't have a physical building. But I think they've expanded into all but 5 counties, which is great. It's a great resource and needed resource for all communities.
Thank you.
Yeah. There any other questions that people have? We do have a website, so people are welcome to visit the website. It talks a little bit about what I already covered, what the services that we provide. We have a partner portal that we have for our multidisciplinary team partners that has access to trainings and events and our protocol, other documents that we use routinely.
Thank you so much, Lindsay. This is super helpful, and I think it just really reiterates that we all have a role in prevention, and it's so helpful to have information for what to do as a community partner, as a mandated reporter, and for community members that interface with our kids on a regular basis to have an idea of what the process is, how I could be supportive without causing additional trauma or interference. And so I think that this is really helpful. And so I really appreciate all the information that you shared. I just also want to thank everybody who was able to attend this webinar. This was recorded, so it will be uploaded to the Kids Mental Health Pierce County website. I do just want to let everybody know we have another webinar next Tuesday, the 25th at 3 p.m. where we will be highlighting another resource with Fairfax Behavioral Health's new intensive outpatient program and partial hospitalization program for youth. So that's another exciting resource that's available. If you have any other questions or ideas for webinars, don't hesitate to reach out to the Kids Mental Health Pierce County team. And again, thank you all for joining us, and this will conclude our webinar for today. Thank you.
Lindsay. And reach out to me too. My contact information's there.
Yes.
Thank you.